Hello and welcome. Today we're diving deep into a specific type of endometriosis, ureteral endometriosis. This is a condition where endometrial tissue, the tissue that normally lines the uterus, grows on or around the ureters. The ureters are the tubes that carry urine from the kidneys to the bladder. It's a complex condition that can significantly impact kidney function and overall health, so let's explore it further. While the exact cause of endometriosis in general isn't fully understood, several theories exist for ureteral endometriosis. The most widely accepted is retrograde menstruation. This is where menstrual blood, containing endometrial cells, flows backward through the fallopian tubes and into the pelvic cavity, potentially implanting on the ureters. Another possibility is lymphatic or hematogenous spread, meaning endometrial cells travel to the ureters through the lymphatic system or bloodstream. Finally, coalomic metaplasia, where cells lining the abdominal cavity transform into endometrial cells, is another potential contributing factor. It's important to remember that these are theories, and the exact cause in each individual case can be multifaceted. The pathophysiology of ureteral endometriosis involves the implantation and growth of endometrial tissue on or around the ureters. This ectopic endometrial tissue responds to hormonal fluctuations just like the tissue in the uterus, thickening, breaking down, and bleeding during menstruation. However, because it's outside the uterus, this bleeding can cause inflammation, scarring, and adhesions. This can then lead to narrowing or obstruction of the ureter, known as ureteral stenosis. This obstruction disrupts the flow of urine, leading to hydronephrosis, which is the swelling of the kidney due to urine backup. Prolonged hydronephrosis can ultimately damage the kidney and impair its function. Unfortunately, precise epidemiological data on ureteral endometriosis is limited. Endometriosis itself affects an estimated 10% of women of reproductive age. However, ureteral involvement is relatively rare, occurring in approximately 1% of women with endometriosis. It's more commonly seen in women with deep infiltrating endometriosis, which is a more severe form of the disease. The lack of specific epidemiological studies makes it difficult to determine the true prevalence and risk factors. The signs and symptoms of ureteral endometriosis can vary depending on the severity and location of the lesions. Some women may experience no symptoms at all, especially in the early stages. However, as the condition progresses, common symptoms include flank pain, which is pain in the side or back, often radiating towards the groin. This pain may be cyclical, worsening during menstruation. Other symptoms can include urinary frequency, urgency, dysuria, which is painful urination, and hematuria, which is blood in the urine. In more severe cases, hydronephrosis can lead to decreased kidney function, which can cause fatigue, swelling, and high blood pressure. Diagnosing ureteral endometriosis can be challenging due to its nonspecific symptoms. A thorough medical history and physical exam are crucial. Imaging techniques play a key role. Ultrasound can be used to detect hydronephrosis. CT scans and MRI provide more detailed images of the ureters and surrounding tissues, allowing for visualization of endometrial lesions and an obstruction. Intravenous pyelogram, or IVP, is an X-ray of the urinary tract after injecting a contrast dye. Finally, cystoscopy and ureteroscopy, where a small camera is inserted into the bladder and ureters respectively, can provide direct visualization and allow for biopsies to confirm the diagnosis. A biopsy is the only definitive way to confirm the presence of endometrial tissue. Ureteral endometriosis can be classified based on the location and extent of the lesions. It can be intrinsic, meaning the endometriosis is within the ureteral wall, or extrinsic, meaning it's outside the ureteral wall, causing compression. It can also be classified as partial or complete obstruction depending on the degree of ureteral blockage. A common classification system used for endometriosis in general, such as the Revised American Society for Reproductive Medicine, or ASRM, staging system, can provide information about the overall severity and extent of the disease, which indirectly correlates with ureteral involvement. Treatment for ureteral endometriosis aims to relieve symptoms, preserve kidney function, and prevent disease progression. The approach can be medical or surgical. Medical management typically involves hormonal therapies, such as oral contraceptives, progestins, or GnRH agonists, to suppress endometrial tissue growth and reduce inflammation. These treatments can help manage pain and slow the progression of the disease. Surgical options include laparoscopic or open surgery to excise the endometrial lesions and repair the ureter. In severe cases of ureteral obstruction, ureteral stents may be placed to maintain urine flow, or in rare cases, nephrectomy, the removal of the kidney, may be necessary if the kidney is severely damaged. A multidisciplinary approach involving gynecologists, urologists, and pain management specialists is often essential. Currently, there are no proven methods to completely prevent endometriosis, and therefore, ureteral endometriosis. However, certain lifestyle modifications, such as regular exercise and a diet rich in fruits and vegetables, may help reduce the risk of endometriosis in general. Early diagnosis and treatment of endometriosis can potentially prevent the development of more severe complications like ureteral involvement. Regular pelvic exams and discussing any concerning symptoms with your doctor are crucial. The prognosis for ureteral endometriosis depends on the severity of the condition, the extent of kidney damage, and the effectiveness of treatment. Early diagnosis and treatment can often preserve kidney function and improve symptoms. However, recurrence is possible even after successful surgery. Ongoing monitoring and follow-up are essential to detect and manage any recurrence. Recent research is focused on developing more targeted therapies for endometriosis and improving surgical techniques to minimize the risk of complications and recurrence. Further research is also exploring the role of genetics and environmental factors in the development of endometriosis, which could potentially lead to new prevention strategies in the future.